Okay, I'm going to start the introduction while we wait for everybody to join. But thank you all for joining us for this week's Miami Global Brain Tumor Symposium. We have very exciting talks tonight, and so I'm glad everybody joined us. Just a quick introduction. My name is Michael Ivan. I'm one of the brain tumor and skull-based surgeons here at the University of Miami and director of our research program for brain tumors. I'm joined tonight by my co-directors, Dr. Morcos, professor and co-chairman of our department and director of the cerebrovascular and skull-based program, Dr. Komatar, professor and program director of our residency program and director of the UMBTI, and Dr. Benjamin, assistant professor and director of our skull-based lab, brain tumor skull-based specialist. Each week we put this on. This is our 26th week ever since COVID started to do these seminars, bringing you information about brain tumors. And I couldn't do it without all the help of our administration from University of Miami, Sylvester Comprehensive Cancer Center, and the neurosurgery department. Thank you, Christina, Roberto, Ingrid, Demaria, and Ignacio. Anybody wants to learn more about our symposiums or about our department, we're very active on social media. You could find us on Twitter, YouTube, Instagram. Also, here's our website is active, and you could find out any other additional symposiums and seminars that are upcoming with our department, including grand rounds that we are now have on YouTube as well. Each week, in addition to our Wednesday conferences, we also have a Thursday conference focused on skull-based and cerebrovascular, and tomorrow's no exception. We have a great panel tomorrow starting at 5 to 7. Looking at augmented reality within the skull-based and vascular surgery with a great panel, Walter Jean, Josh Peterson, Akeo Morita, and Bernard Bendock joining us to give us their experiences on augmented and reality within surgery. And a quick teaser for next week here on our Miami Global Brain Tumor Symposium. Valerie Zade is going to be joining us from the University of Toronto talking about methylation signatures, introducing a paradigm change in neurosurgery. She's also will give us a sneak peek in the Society for Neuro-Oncology meeting that'll be happening virtual next month, and as she's the current president. So housekeeping, we try to make this as interactive as possible. Please use the Q&A button, and we'll try to get to as many questions as we can throughout the evening. We don't offer CME, but you will get a confirmation email documenting your participation. And please be sure to like, follow, and share our videos so we can continue to grow and share all the amazing knowledge that we get from our amazing speakers each week. You could also follow us on YouTube if you missed part of tonight's talk. But let's get to tonight's panelists. They're really all visionaries when it comes to laser surgery in the brain, starting with Shavar Danish, who's a physician and neurosurgeon at Rutgers Wood Johnson in New Jersey. He's associate professor and chief of the section for neurosurgical oncology. He's also director of their Gamma Knife Center and Laser Ablation Treatment Center. Ian Lee is a neurosurgeon and brain tumor specialist in Detroit, Henry Ford Cancer Institute, and part of their brain tumor center as well. Just completed the second neurosurgeon in the United States to do lit surgery for the spine. When it brings into our next speaker, Claudio Tatsui, who is the first person to do spine lit, joining us from MD Anderson. He's associate professor who focuses on spine tumors, on neuro-oncology. And we also have Spiderman Hant, a frequent visitor here on the symposium. He's assistant professor, specialist of minimally invasive neurosurgery, and the chief of neuro-oncology at Westchester Medical College and Nerd College Medical College. Thank you all for joining us tonight. Tonight, we have a very special keynote speaker, Dr. Luthart, who's joining us from Washington University in St. Louis. He is a professor of neurosurgery, but also part of their neuroscience, biomedical engineering, mechanical engineering, and material science departments. He's the chief of the Division of Neurotechnology, director for the Center of Innovation Neuroscience Technology, and director of the Brain Laser Center, also at WashU. He's very, very well known for his work on lasers, but also on his research focused on brain-computer interface, which he focuses his lab on, and brain mapping. He uses engineering approaches to decode the brain, create novel diagnostics and treatments for the disease ranging from brain tumors, stroke, chronic pain, and spinal cord injury. He has many publications and awards I'm not going to go into tonight. He also has multiple patents on all his device. He's a founder and CEO of his company called Neurolutions, up on the top. He's also, if that wasn't enough, in his spare time, he also is a creator, writer, and actor in the new PBS series called Brainworks, the Theater of Neuroscience. and he's a New York Times bestselling author for his fiction novels, Red Devil 4 and Limbo. I don't know how he finds all the time to do all that and be a fantastic surgeon and also join us tonight, but I thank him so much for taking the time out of his busy schedule to give us his thoughts on laser interstitial thermal therapy for brain tumor and brain lesions.
Well, thank you very, very much for that kind introduction. Let me share my screen here, and hopefully you can see that. Oops. Let's see, can everybody see that?
Yeah, that looks good. Thanks.
Okay, great. Well, first off, thank you again for the opportunity to speak, and thank you for for that very kind introduction. It's a real pleasure. Hold on, I'm just going to adjust my. The panel of speakers is actually obstructing my view. So let me try this again here. Okay, great. There we go. Oops. So let me start with obviously I'm going to talk about laser interstitial thermal therapy, or LIT, or MRI guided laser ablation for brain tumors, and the experience we've had at Washington University. And before I get started, let me just kind of march through my disclosures. I'm involved in a number of a startup company, as was mentioned. I'm a consultant for Monteris, which I think is really the most relevant disclosure here. I do some consulting for them, and I use their technology clinically. Got a number of licensing and IP, and Washington University does own some of the equity in one of my companies, Neurolutions. So, I think really kind of where we begin is, as neurosurgeons, we're really confronted by tumors in patients that really cause us to have hesitation, that where we're really trying to weigh the balance of kind of how do we deal with difficult tumors or patients who are too fragile to get standard surgery. And it really leads to this fundamental tension between, on one side, as a neuro-oncology surgeon, we want to remove as much as possible to kind of deal with the cancer that we're dealing with. Although conversely, we're always balancing that against functional preservation, meaning in some senses, we want to remove less. We want to preserve function as best as possible. And how do we basically maintain that optimum of maximally aggressive, safe surgery against, best preserving a patient's function? And I think that's where stereotactic laser ablation, laser interstitial thermal therapy, it has a number of names, but this minimally invasive deployment of laser probes into the brain really provides, I think, an emerging and unique opportunity to treat our patients. And to me, especially for kind of if there's residents watching or some of the early trainees, this to me is really kind of a segue into, I think, really a much broader field of how we think about managing tumors, just as we've seen in vascular surgery, kind of this interventional vascular approach. I think we're similarly seeing this sea change of what I consider interventional neuro-oncology, where we're using highly minimally invasive approaches to treating diseases that were historically considered open or even considered non-surgical. And so really kind of, what is kind of laser ablation? Well, it's, as I mentioned, it's minimally invasive. These probes are on the scale of millimeters in their maximum width. They're typically MRI guided. They're real time in that the heating that is created by these lasers is monitored by an MRI scanner, and they provide real-time hands-on control, meaning you can control the position and the heating of the laser that you're using to treat the patient. So, and again, here's just what I use, which is kind of the Monteris system, and just kind of an animation of kind of how it works. But basically, as you can see here, there's a skull bolt, inserted into the skull, and then a probe is kind of placed through that bolt, and it's controlled by this MRI compatible robot that can move the probe backwards and forth and rotate it. And the idea here is that by controlling the heating and the positioning of this, you can create a relatively conformal kill zone with that laser probe so that you can treat a tumor or other lesions. And, again, this is beyond the scope. We can also treat epilepsy, basically with that minimal both skull and cortical penetration. Now, in addition to that, one of the things we use at Washington University is using the ROSA robot. And I think that this allows us to really be highly precise in where we place our laser probe. Specifically, that robot is extremely useful for the precise placement of that skull bolt, which then really allows us to have the optimal trajectory to getting at our lesion. And I think really kind of this is what it comes down to, is that here you have that skull bolt, which is implanted in the skull, and that's kind of what it looks like intraoperatively. And postoperatively, you're left with a very, very small incision that's usually closed with 1 or 2 sutures. So when are we using this at Washington University? What are the typical indications? And we reported on our early experience back in 2017, and kind of here's a breakdown of generally the applications. And you can see with that pie chart, a large component of that is glioblastomas, but also a number of gliomas of various grades. Metastases is kind of the close second, and then radiation necrosis and radiation necrosis and epilepsy follows that. And I think one of the learnings of this, and I think this is really important, because when you first start using this technology, it takes a long time. There's a lot of technical steps to this that can make it fiddly. But I think you can, as you progress in your experience, that we really have created a workflow and efficiency such that these cases typically take us, approximately 2 to 2.5 hours skin to skin, which I think is makes it a very feasible operation for patients and just general surgical workflow. I think other learnings from just the general experience of doing a number of these cases is that historically, like our time for how long these patients stay in the hospital, in addition to surgical workflow, I think our just general care workflow is really improved in that typically these patients now are not going, whereas with our first 120 patients, they would go to the ICU. Their hospital stay was about 2 days. Now I think we don't send our patients to the ICU, and increasingly commonly that sometimes we're discharging them the same day, and this is incredibly important in this current COVID era. I think the other big takeaway from this, just the general 10,000-foot view, is that when we look at our complication rate, that the volume of the lesion that you treat matters. The bigger you get, the higher risk of having problems such as swelling or hyponatremia or seizures. And really a good just kind of mental cutoff is approximately 3 centimeters. I think under 3 centimeters, the risk of complication tends to be relatively low. Above that, it becomes higher. Not prohibitively so, but it's something to keep in mind. So kind of indications, and again, I'm just going to run the list here, and then I'm going to really walk through some of these and highlight some of the literature associated with it. Kind of where we started was inoperable or difficult to access tumors, recurrent gliomas and glioblastomas. I think that's a real workhorse. Refractory brain metastases, radiation necrosis, epileptic foci, meningiomas, cavernous malformations. And I'm going to highlight also that the laser approach, I think, really serves a number of clinical protocols and clinical trials in a really unique way. So again, I think where we started when we started doing this 10 years ago was really using this technology for tumors that were really largely considered inoperable or very difficult to access. And here's a classic example of a thalamic glioblastoma. Here's kind of what the patient looks like 1 year later. And again, I think that has been very fruitful, and that I think these patients tolerate the surgery well. Another kind of classic difficult to access tumors, tumors in the insula and the deep gray matter beneath the insula. Again, here's an example where basically, again, a patient with a insular glioblastoma. Here he is 2 years later after his treatment. And again, I just want to walk through a case in a little bit higher detail, because I think that these insular tumors, now again, insular tumors, you can't say that they're inoperable, but they have a higher level of technical complexity. And so here's an example of one of the patients that we treated I think is worth highlighting. Again, a 58-year-old gentleman. He had some headache. His headaches progressively worsened. And then he eventually developed slurred speech and word finding difficulty. And he presents with this kind of deep set, kind of insular slash tumor that's in kind of the temporal stem. And I think that a lot of people, when I remember reviewing this case, really felt, open surgery may be difficult here, really kind of, relegate this gentleman to biopsy alone. But, we really, as we worked him up, we saw that, again, it's in close proximity to a number of functional structures. This is kind of our amalgamated imaging, which shows kind of both resting state fMRI as well as DTI tracts, such as the corticospinal tract and the arcuate fasciculus. And really, this tumor is close to a number of things, whether it be the arcuate fasciculus, the corticospinal tract. And so we made the decision to treat it with laser. And again, I just want to show you a video of this. Let's see here. Whoops. Let's try that again. There we go. And again, those bolts that you see on the skull, we use skull fiducials to co-register with our ROSA robot system, so I think we get a high degree of accuracy. Here you can see the tumor in a three-dimensional representation. One of the things that was notable here is that it was quite close to middle cerebral artery and its branches. There in orange, you see the arcuate fasciculus. In the blue, you see the corticospinal tract fibers, and it's extremely close medially. So we were able to just kind of define a kind of parietal trajectory with 2 probes, where I think we got the majority of the volume there. And what you see in blue is the actual volume treated. That we were able to get greater than 90% of the volume treated for this tumor with kind of the 42 degrees Celsius for 10 minutes. That's kind of the true kill zone, but the yellow zone of 42 degrees Celsius for 3 minutes fully encompassed the volume. So kind of here's what it looked like post-operatively. Again, the gentleman was a little bit more phasic after surgery, but by a few weeks later, his speech was largely normal. And here you can see him 4 months later. And really kind of the edema is gone. You still have the kind of lesion from the laser, but with, really just this thin rind of enhancement that's very standard for what you see in the post-treatment phase. And then he went on to chemoradiation, has been doing well. And I think that when we think about these difficult to access tumors, we have historically compared them to biopsy only patients. And it's pretty clear if tumors are in what we call this favorable group, where basically they have a volume of, less than 10 centimeters cubic volume, and you treat the majority of the volume of these tumors, these patients do much better than biopsy-only tumors. So I think that's really worth keeping in your mind. Again, I think other tumors that we've historically considered really not operative are glioblastomas in the corpus callosum. And kind of we have a smaller series on this. And again, we've looked at 15 patients with glioblastoma. And again, for recurrent tumors, we found that, where patients have recurrent tumor in the corpus callosum, that the recurrence was around 20 months. So we had a very satisfying outcome with those patients. De novo patients, their overall survival was, 7 months. That's obviously not that great, but compared to, I think, how these patients typically do, I think we do a little bit better than that. But I think this for the de novo patients with the corpus callosum GBMs, that, I think, there's probably more work that needs to be done to figure that out. I think one of the big workhorses for laser in our experience has been a recurrent glioblastoma. And I think the experience has been extremely satisfying. And I look forward to the input on the panel as well here, where again, I think we really give some patients some real benefit. And just here's an example of a patient with foconodular glioblastoma. And this is what the patient looks like 8 months after their laser treatment. Now, again, when we think about recurrent glioblastoma, really the question becomes, what is the evidence for, really pursuing maximal extent of resection for recurrent GBM? I think we've relatively accepted that, again, we want to do maximally safe surgery for, upfront tumors, but what about a recurrence? And again, one of the works I'd like to cite is, work by Oren Block, where he really looked at the impact of the extent of resection for recurrent glioblastoma. And in his work, he was pretty clear that basically there is evidence for patients, even when controlled under multivariate analysis for overall survival, that extent of resection makes a difference for these patients. And Lou also further did a meta-analysis on all the papers that were out there. And again, I think what we find is that maximum extent of resection for recurrent GBM seems to confer a survival benefit. And this may be even independent of the initial extended resection for the initial surgery. And I think, where I really think that laser really comes into sharp focus here is when we look at some of the work by Nader Sinai. And again, what he demonstrated in his evaluation of extensive resection for recurrent glioblastoma is if you can treat greater than 80%, that you get a median survival of about 19.2 months. And if you can do greater than 97%, the median survival is around 30 months. But I think a huge caveat here is that as you increase that extensive resection with open surgery, that you have a much higher neurologic morbidity. And I think that's where laser can really provide a role here of maximizing that extensive resection, but reducing that morbidity to really giving people the most optimal median survival. So again, just to show you another case, here's a 69-year-old woman who again had a glioblastoma, again in the right deep parietal lobe, adjacent to the ventricle there. Kind of here's what it looked pre-op and post-operatively. And again, as with the vast majority of glioblastomas, she was confronted with a recurrence, but this time in the pulvinar of her thalamus. And again, this one we treated with laser. And I think what was really interesting here is, and again, she's in a trial, which I'm going to talk about in a few moments, where we combined laser with a PD-1 inhibitor. And I think what's exciting about her is that we treated her and basically she was discharged the same day. And then here's what her kind of treatment looks like 2 months post-op. And again, she was treated during the COVID era, where again we were really limited in our bed and ICU infrastructure. And so having the ability to treat these patients and send them out the same day, I think is a huge boon right now. In addition, that I think if this would have been done open, I think that there would be a higher level of morbidity. And so I think this is really an example of how we can strike that right balance of cytoreduction with reduced morbidity. So we recently published, I guess not so recently, it's now 2 years ago, but basically our early experience with kind of glioblastomas, looking at our initial patient population of 58 patients with GBM. And in terms of kind of what we were able to accomplish, that in terms of the mean tumor volume, which is approximately 12.5 centimeters cubed, that basically we were able to cover approximately 93% of that volume with kind of what is 43 degrees Celsius for 2 minutes, heat equivalent or heat dosage. And about 88% of the volume was treated with 43 degrees Celsius for 10 minutes. Our complication rate, I think, was around 15.5%. But again, these what we term as complications tend to be, relatively mild, meaning you have some edema, seizures, hyponatremia. We had one patient with hydrocephalus and one infection. I think, one of the key takeaways here is that when we looked at our experience for recurrent glioblastomas, that kind of their overall survival from the time of treatment was 11.8 months. And I think when you look at that relative to kind of the benchmark for overall survival for kind of the treatment of recurrent glioblastoma, which I think really is the work done by Wick et al. In the New England Journal of Medicine, where they demonstrated in phase 3 trial of using lomustine and bevacizumab, that the overall survival for that was 9.1 months. But now there's numerous publications, ours being one of them, with a high number of patients that we're averaging around 11.8 months. So I think that you're giving people very meaningful survival from their recurrence with laser therapy. And I think, in addition to that, what I think is really exciting about LIT, in addition to its ability to accomplish cytoreduction, is that it really can enable a number of clinical trials by the fact that it breaks down the blood-brain barrier. And again, everybody in this audience is going to be relatively familiar with the blood-brain barrier, but it basically there's a number of tight junctions in the capillary endothelium, which prevents egress of larger molecules getting into the brain parenchyma. And one of the things that we really noticed early on as we were treating tumors is that after you've treated that tumor, there typically is a rind of new enhancement circumferential to the treatment zone. And we really kind of dug into this in our human subjects by doing a number of advanced MR techniques and looking at kind of the vascular permeability with MRI, and found that basically the blood-brain barrier is broken down for approximately 4 weeks after the treatment. And so that really gives you an opportunity to give additional agents during that time frame that could supplement the cytoreduction that you accomplish with the laser. And, and some work that I really want to highlight that was performed by Dr. Albert Kim, who's kind of, one of my partners here, is he really unpacked the mechanism in animal models for what happens. And really, it's more than just, hey, you've created an injury here. And basically, really, there's two fundamental pillars of how laser heating alters the blood-brain barrier. First, it's altering the tight junctions. And then in addition to that, and it's quite distinct from kind of sham, where basically you put in a probe and you don't heat it. But also it's really enhancing endothelial transcytosis, where basically you are seeing blebbing that's allowing you to kind of really have, enhanced transition of, molecular agents to get through the blood-brain barrier. Now that's really enabled us to do a couple of clinical trials. We currently have 2 clinical trials, one which just completed, LIT plus doxorubicin. And doxorubicin is a cytotoxic agent, which is one of the most blood-brain barrier impermeant agents. But it is in vitro models is quite cytotoxic to glioma cells. So it's really a perfect agent to test this. We just completed that, so stay tuned on the results of that. And we're also combining LIT with immunotherapy and anti-PD-1 antibodies, and we're currently enrolling for that. And both of these, I'd say the preliminary evidence is quite intriguing for this combination seems to be having an effect. So, to really kind of move on, I think another group that we really like to treat with laser are metastases, very specifically metastases after post-gamma knife treatment. Because I think, a number of neurosurgeons, I think, are often confronted with this situation where somebody, there's a patient who's got their systemic disease controlled, they've got a metastases, it's been treated by gamma knife, it's in a location that would not be ideal surgically, but now we see evidence of the tumor coming back. And really, some of our early experience with LIT was also in these recurrent metastases. And so we've now, kind of accumulated an experience with this, and this was also kind of published a couple of years ago, where it seems that basically we were able to, enhance median overall survival with patients with metastases post gamma knife to approximately 13 months. And that typically tends to be because we get their central disease controlled. So I guess, where I want to start to transition is some of the emerging clinical applications. And I think really one of the exciting areas that we're getting really interested is how do we use this for low-grade gliomas? And first, is it reasonable to consider this for the initial treatment of a low-grade glioma? And I just want to show you an example of one of the patients that we, one of the early patients that we worked on. Because I think one of the things that's, very different when you think about a metastasis or, a glioblastoma, there's a certain element of time urgency where you really got to get this taken care of. Whereas with low-grade gliomas, because of the time scale in which they grow, you have more time to kind of treat this. So this idea of doing staged treatments becomes feasible. And so this is an example of a patient who had kind of this, larger insular glioma. And the woman, honestly, I was planning on doing an open surgical resection for her, and she was not having it. She was dead set against having an open surgery. And so, at the time we were doing lasers, for high grade tumors, and we compromised, and we said, well, why don't we do some staged laser ablation? So we, treated a portion of the volume of this tumor in the first stage, waited a couple months, and then we saw what was left after that initial treatment. Then we treated that. And then basically she went on to radiation and chemotherapy, and this is what we were left with. And this case to me was a really eye-opening opportunity that some of these difficult to access lower grade tumors, you don't have to do them all in one go. that you have the opportunity to essentially carve away at them and then combine them with other adjuvant therapies that I think really can, provide, significant and meaningful benefit. Because I think also each of these lit treatments where, she went home the next day and it was extremely well tolerated without any morbidity. So I think that's, again, I think an emerging one where we're starting to use this more and more for some of our difficult to access low-grade gliomas. Now, again, the full disclosure that one of the things we have to think about is, and this is what I discuss with my patients, it's hard to know whether kind of this treatment is equivalent to an open surgical resection in terms of, kind of time of recurrence and overall survival. And that really requires, further study. But at least initially, some of the findings that we've seen as we've treated some of these patients, at least in terms of the imaging, have been really, really quite satisfying. And I think then that really begs the next question: what about recurrent low-grade gliomas? And again, whereas I think the initial data for resection, upfront resection of these lower-grade gliomas, such as IDH1 mutant tumors and TERT promoter mutant tumors, I think is really becoming, kind of really standard. The evidence is still kind of, emerging for recurrent tumors. And so, what is out there is that, and this is a work done by Ramakrishna back in 2015, where they started to look at, the extent of resection, and really, the extent of resection of tumor really played a role in overall survival in this series of roughly 60 patients. And really, in their multivariate analysis, it's also worth noting is that any residual disease after the first or second surgery seemed to impact overall survival. And again, I'd like to show you an example here, and this was done by my partner, Albert Kim, and I think it's a really lovely example. Here's a patient, again, who was originally treated in 2012. And again, there was some residual tumor left behind, and really, over the years, there is this steady growth that you can see from 2015 to June of 2019 to September of 2019, where most notably that insular component of the tumor is getting bigger and bigger. And so basically now kind of, here's what you have both in the insula and a component of the hippocampus. This was treated with a biopsy plus kind of a two-stage lit, followed by adjuvant temozolomide. And again, here's what it looks like, after stage one, here's before stage one, excuse me. And then here's what it looks like 4 months after stage two. And you can really see that, again, that's a very nice result of, cytoreduction and without having to do open surgery. And each of those stages was a single day procedure. So I think, and again, I think I'm hopefully on time here, is that I think laser is really playing a larger role in the management of brain tumors. I think some key diagnosis for treatment include difficult to access gliomas, recurrent gliomas, metastasis post-radiation. And I think a really exciting avenue that I think is going to really expand is lit for recurrent gliomas really can enable novel clinical trials by the fact that they break down the blood-brain barrier. And so I think that this really becomes a corridor for really engaging a lot of other chemotherapy and immunotherapy agents that would have otherwise not been used on brain tumors. So with that, I'd like to say thank you. It's a great pleasure to work with the people that I do at Washington University. That's a lot of people kind of who, do laser as well as contribute to the whole laser effort. And again, I'd be happy to take any questions at this time. Thank you.
Thank you, Eric. That was awesome. Really, really great work you guys are doing there. And we're looking forward to seeing the outcomes of the 2 clinical trials that you talked about. A couple questions from the audience here before we get to our panelists. Dr. Ordonez asks, when you talk about the extent of resection with open surgery, Notter's paper and Oren's paper, do the same percentages equate to lit extent of resection? Do you think it's exactly 1-to-1, or do you think there's still research to be done?
Still research to be done for sure. Some of the work done by Dr. Mohammadi at the Cleveland Clinic, basically it's at least the initial evidence when we compare it against, biopsy only tumors, that getting more than, 97% of the volume seems to confer the maximal benefit.
Dr. Xiao asks, how does laser ablation combine with radiosurgery? And this is a great question because, it brings up the question of for newly diagnosed gliomas, that are deep, some of the ones you showed. Are you doing the same protocol as far as radiosurgery and chemotherapy at the same time course for recurrent metastasis? Are you not?
That's also a great question. Now, there is, again, this is preclinical data, meaning that, like, it's in animal models, there does appear to be a synergistic cytotoxic effect by combining laser heating and radiotherapy. So, and again, this is one thing that we're exploring for metastases is, there's these, when you look at metastases between, 2 and 3 centimeters in maximum dimension, while Gamma knife still is the standard of care there, that control for, as you start to approach 3 centimeters, it roughly starts to get at around 60%. So we're starting to contemplate doing combined therapy with radiation first, followed by laser. And again, our preliminary results there seem to be encouraging. But again, there's more work to be done. To answer the other question that Dr. Ivan just also asked, was that what are we doing in terms of our for upfront glioblastomas? We are really doing standard protocol, meaning that we do the laser and then we go to chemoradiation. I think one of the slight differences I would say is that we can get them to chemoradiation much sooner. So I really, because of that understanding that basically we've broken down the blood-brain barrier for 4 weeks, I really want to get them in as soon as possible to maximize the potential benefit of giving them Temodar during that time.
Are you biopsying all of your patients that you do lit on, or just some of them? And how are you choosing?
That, again, these are great questions. I would say for upfront tumors, absolutely, we're biopsying all of them. For recurrent glioblastomas, we are frequent. I'd say the vast majority of the time we are biopsying them because we want to see if there's any actionable mutations, whether they're hypermutated, which can have an impact on whether you give them immunotherapy. For Mets, I'd say it's more variable. I'd say the majority we are, but if it's really not going to change the care of that patient, sometimes we don't biopsy for recurrent Mets after gamma knife radiation.
Right. And the other question I had too for you is, obviously your initial paper on the breakdown of blood-brain barrier was so critical and really and one of the first one that put it on paper, and I congratulate you. That I think it's been cited probably, I don't know, hundreds of times. But you looked at different time points there that were pretty far out, like 7 days, I think, and 14 days. But do you feel that the breakdown is actually most optimal in the first 72 hours after lit, or when you're doing it and when you're combining, or do you feel like there is a peak that is occurring at a certain time point that's optimal? And are you using that idea for the doxorubicin trial?
Great question. So there is kind of a downslope, basically, but it really, and especially also when you look at Albert Kim's work, it really is open, for about 4 weeks, and then it really does drop off to nothing. And that was true kind of in humans as well. I think it probably is more open, in those first couple weeks, as you look at that curve. But that's why, given that. If I, for instance, if I've got a, Met and I laser it and the oncologist wants to give chemotherapy after that, I would love them to do that days after we do that laser to optimize that potential benefit.
And what do you think about the immune, I know you're doing the PD-1 inhibitors, but do you feel like with glioblastoma especially, there's a variation with immune suppression, and there's a certain immune stimulation of the lit? In our patients, we kind of wrote up a preliminary paper looking at the neutrophil lymphocyte ratio, and there's definitely some correlation to how some people respond more than others, depending on their immune status. Have you guys seen that, and have you seen that also with the PD-1 patients?
Yeah, it's something we're absolutely investigating right now, and I don't have an answer for you yet. But again, just that the thinking is that, and again, you bring a great point, is that heating, is it converting a immunologically cold tumor to a hotter tumor by the fact that you essentially induced a burn? Because we all know that, with the increased amplification of heat shock proteins, that there is that will make it more immunologically excitable, and that's part of the hope with these immune stop inhibitors, that you're going to capitalize on that benefit, in addition to the fact that you've broken down the blood-brain barrier, and in addition to the fact that you've killed a bunch of tumor and left a lot of dead antigen behind.
Right. There's a couple other questions, but I want to get to our panelists. Dr. Danish, are you you want to start?
Hey there. So how do you want me? You want me to share my screen here?
Yeah, that'd be great.
Okay.
Or should I stop sharing? Yep.
Let me just bring up my thing here. Give me 1 second.
While we're waiting for him to bring up his, one more question from Nikolai, talking about the role of artificial intelligence in optimization of LIT and perhaps combining that with other therapies. Have you thought about, I know your lab does a lot of AI work. Is that something you guys are working on or look to in the future?
I can't say we're directly working on, it's a great idea, but this idea of like, how can you fully personalize and really make, essentially create precision of the combination of laser plus a variety of treatments based on the treatments, the laser, and kind of the genetic features of the tumor. I think that's essentially a white space that needs to be filled. I would say the other thing where I think that AI could potentially be useful for is, whereas we do have, for instance, with the Monteris system, we have a side fire laser, and even with diffusion tip lasers, what is not always obvious is the rate and direction where the heat goes. And I think that to me seems like an opportunity where you can start to use more advanced techniques based on the imaging, maybe the perfusion, to get a deeper insight where you think the heat's going to go. And I think because we're beginning to aggregate the scale of data where you can start to use that AI to train it, I think that also is another interesting possibility, using AI.
Sure.
All right. Well, so actually, I think that was a great talk by Eric, and I guess the things I'm presenting actually maybe dovetails nicely well with what Eric was saying about these interesting COVID times that we live in. So actually, let me back up one. So this is a patient that actually came to me in April with a new onset of seizure, neurologically intact, but actually left-handed, and had a mostly T2 flare hyperintense lesion, but with that little dot of enhancement in the middle. So with the new onset of symptoms, I felt like this was not something that we could really wait on, even though essentially all of our elective surgeries have been canceled at that point. And so I kind of pushed hard we had talked about doing an open surgery, but in the end, given that our hospital was sort of overrun with COVID at that point, we decided that we were going to do a laser ablation of this and try to get him out of the hospital very quickly. So, and it sounds like Eric, you had some cases
Mm-hmm.
like this as well. Yeah,
absolutely. I really love these low-grade insular tumors for laser. I think they're, and again, I love doing open surgery too, but you really just avoid kind of the vessels. I feel like the thalamus striates tolerate the laser. I have not seen a thalamus striate stroke
right.
that you sometimes see with resection. So it's really been very, very satisfying.
Yeah. So I'm mainly a Visualase user, and the main downfall of Visualase, I'd say, is that you can't get as large of a lesion as you can get with Monteris. So we did use Visualase for this, and in the top image, you can see that we used 2 fibers, and in the bottom 2 images, this is actually a 6-week post ablation film. So you see there's a little bit of the anteromedial portion that we didn't quite get to, but still, it was a good ablation. He went home post-op day 1, neurologically intact. Never really had any problems post-operatively with edema. For that particularly post-sterile superior part that, if done in an open way would be the riskiest part, like you're saying, we didn't see any kind of infarct related to thalamus striates or the M3 perforators from the insula.
I'd say
sorry. Go ahead. Yep.
As the one area, we've done a number of these inserts. I'd say the one area of maximum risk, in my opinion, when we think about these insular ablations, is the posterior cephalad aspect of these insular tumors. So kind of if you imagine kind of like in that left panel, kind of that very posterior aspect, and then you go a little bit superior, you can start to see that backside, that posterior aspect of the internal capsule comes close to that. So that's the one warning I'd have for everybody, is that when you get posterior and high on the insula, you got to be pretty careful of the internal capsule.
Okay. And then here's just one other case. This is actually a young woman who I've been following for about 1.5 years, who had a clearly progressive left-sided insular tumor. She was right-handed, but really, was too afraid to have open surgery. And I wasn't at that point ready to take on insular tumor with laser ablation. And based on actually that experience with that last patient, I did actually offer her an ablation. She actually she decided to do it during COVID times because she was off work anyway. And so it was kind of fortuitous that we were able to get it done. And we did this one in May when the hospital started to open up again for elective procedures. Mm-hmm. And I guess the question for this one, now I did do this in a staged fashion. The first time, so this image, sorry, the one on the right, just to show that there was a part of the tumor that was in the temporal lobe. It wasn't just purely insular. Mm-hmm. Mm-hmm. And we did it in 2 stages. This is the first set of ablations where we used 3 fibers, 2 going through the insula, then 1 laterally into the temporal lobe. Mm-hmm. Mm-hmm. And she did have some issues post-operatively that lasted for about 6 weeks with sort of a mild to moderate aphasia that actually, by the time she got to about 6 weeks, was basically back to normal. Mm-hmm. I guess, this tumor that I'm showing is not it's not that large as opposed to the one that you showed. Mm-hmm. At what point do you worry? She definitely had, aphasia issues after surgery. Is there a volume that if you're going to do it in a staged way, is there a volume that you look at?
Yeah, that's a great question. I mean, typically kind of my rule of thumb is 3 centimeters in maximum diameter is what I try to stay under. If I'm going to do a stage, like almost like a 3 center column, right? So, so I can treat a larger column, but that seems to be kind of the, again, and also in the, what we've, seen in the numbers, but basically if I do a single pass with a, and again, Monteris is a little different than Visualase in that, like, you can create a 3 centimeter sphere or ovoid of kill. It's probably a little bit bigger. So, if I can, for the stage, I try to keep it at a single pass if I can. Or I'll do 2 passes if I'm going to do 2 smaller columns to basically combine to, make it more kind of consistent with the volume morphology. But that to me seems to be kind of the maximum dimension that I try to stay to make it as asymptomatic as possible for the staged approach.
Okay. So
are you using preoperative, DTI and functional MRI in these cases to really map out everything? And are you trying to push up to those limits, or are you using a margin, or what are you using?
Yeah. So, so we definitely use DTI and to map out the arcuate fasciculus and the corticospinal tract. As far as I'll let you've got, for Monteris, you've got your blue line and your yellow line. Your blue line is 43 degrees Celsius for 2 minutes. Your blue line is 43 degrees Celsius for 10-minute thermal dosage threshold, and then your yellow line is 43 degrees Celsius for 2 minutes. So it's kind of a lower thermal dosage. And I'll let the yellow line, that lower thermal dosage threshold, kind of impinge upon a DTI tract, but I try to keep the blue line, that higher thermal dosage threshold, outside of, I can have it a butt, but I try not to have it go into a corticospinal tract or the arcuate fasciculus. And that's also true for if I'm coming close to kind of, for functional, we use resting state fMRI to map out our networks, and I'll do the same for that.
We use a lot of DTI. We don't do a ton of functional MRI. It's our radiologists don't want to process the images for us, so but we do a lot of DTI.
Well, stay tuned. I'm trying to fix that. Hopefully there'll be something available we'll
Yeah.
have resting state available for everybody, hopefully in the near term.
So stage 2, so I let her recover over about 6 weeks, let her speech come back to normal, and then we did stage 2. This one, so I think what I want to point out here is that, so I did leave a rind, the part in the middle here was untreated, and then there was also a part in the anterior temporal pole that was also untreated, and so I did a second series of ablations, one through the middle of the insula, and then another one actually trying to get that temporal pole, and so that actually went really smoothly, and she, this time with this series of ablations, did not come out with any deficits, and so she was very happy about that she didn't have to go through the aphasia again.
Yeah, it's a beautiful treatment. It's really nice. So
I guess my question is, so if there is any residual here, it's going to be the part that's just adjacent to the peri-insular sulcus. The cilium fissure and peri-insular sulcus probably acts as a heat sink and prevents the ablation from getting all the way out there. Is that something that you've noticed at all with your insular ablations?
Maybe a little bit. Yeah. I mean, not always though. I mean, sometimes, I will, when it comes to kind of that insula and the MCA branches, I tend to be fairly aggressive because I think that those, high flow vessels tend to tolerate the heat pretty well. Now I won't, I don't feel too uncomfortable about letting the blue kind of overlap some of those vessels. The white, the really, really hot, or if I don't want the probe to be adjacent to a larger vessel where it's, getting up to 60 degrees Celsius, but I will push it a little bit. Every once in a while, you do see some rind of tissue there, but I think overall, this looks like a really nice response. Now, and that's 6 weeks, you may see that, involute even further as you go out to, several months.
Yeah.
So I guess the other question I have is, is she going to get adjuvant therapy such as radiation and chemo?
So she is. I think we need, it's she's not in a rush to do so, but eventually she's going to. Part of the issue for her is that she also wants to do fertility preservation, so we're sort of do that as well.
Yep. Yeah, I guess the one thing is, I if I can, I try to really after that final stage of therapy, I do try to lump in the chemotherapy to get as I mentioned the blood-brain barrier benefit.
Yeah, actually on our side, in our early experience, we had some patients who developed some pretty malignant cerebral edema, combined lit plus radiation, especially radiosurgery. So our radiation oncologists are a little bit gun shy when it comes to doing radiation immediately after lit.
Although maybe do the radiation first and then the lit. That's how we do it here.
Oh, okay, that's a good idea. All right, well, those are my slides. Thank you.
Thanks so much, Ian.
Those are nice cases.
Shabri, you want to give another go? There you go. Just unmute yourself.
Okay, can you hear me?
Yeah, it's good.
All right, so I'm actually not going to, present cases. I'm actually going to present, some questions I've been, struggling with answering, and actually good to have the panel. And Eric, I think I'd love your insight on this. So, and before this, actually, when we talk about gliomas, I heard you mention something about, flipping the time course, in terms of radiating and lit. And I want to get your take on this. For those of us who have been doing lasers for a while, you start to see that, no matter what your tool is, like these larger gliomas, you really sort of struggle with trying to do it with, not creating issues or morbidity and sort of this tug of war slide that I love. And so recently for some of these bigger, not easy to operate on tumors, I have actually let them do biopsy plus tube protocol, let the radiation actually take a 15 cc tumor and shrink it until, at the 6 to 8 week mark, it then goes from 15 cc's to 8 or 9 cc's. And I think traditionally you say, well, the patient's doing okay, we'll see what happens. And we know what happens. They ultimately recur. And I said, well, at the nadir of that volume, go ahead and ablate it, and does that change the time to recurrence is the question that I think that exists. And I don't know what your thought is on something like that.
No, I think you make a really great, I actually I had, again, yet another insular case. I had this, older woman who she had a pretty decent sized, insular glioblastoma, and she was frail. And so, we did just a biopsy and radiation. And I think it was like, 5 centimeters in maximum, kind of AP length, and maybe, 3 or 4 centimeters, and it shrunk down. And again, we totally did a laser after that, and she did,
Right.
and she really tolerated well. I think that now it's an open question of, whether that makes a difference, but intuitively it seems like it would. I think, because I think that, that when you radiate and do chemo and there's a, still a bulk of tumor there, that they're not going to do that great.
Well, it's gonna, and so that in the laser world, we all say, yeah, that makes sense. But in the broader world of people getting these treatments outside tertiary care centers, you say, what do you really need to move the needle to the right? I mean, that's a much more complicated question. So let me, I know I have a couple of minutes here. Let me try to pose some questions here. So I know we didn't talk a lot about this, but I've had my own personal struggle here with this idea of recurrent brain mets and or radiation necrosis. Now we're all familiar with this scenario, right? You treat it with radiation or radiosurgery, it grows, patient's asymptomatic, you do non-invasive imaging, and then you sort of struggle like, well, what is it? And you sort of wait, and then you do a needle biopsy, and you hope that gives you an answer, but ultimately you're sort of, you're giving this thing time, and ultimately it becomes a much more harder thing to treat. And I think this is a very common scenario for us as, in neuro-oncology, and much more common in the laser world. And I think that what I've struggled with is actually trying to define this question. Is it radiation necrosis for recurrent tumor? And in the world of laser, where we potentially treat these things the same way, I wonder if the standard algorithm to try to differentiate these two entities still makes sense. Right? Here's a case that, you think it's cold, you give it Avastin, it doesn't work, but unfortunately, then you're dealing with a much bigger volume of disease.
Yep.
So, you say, well, maybe we should have done biopsy. And the challenge is that sometimes a biopsy is clear, right? But you're ultimately just getting a small sample of a larger specimen. But a lot of times it's indeterminate, meaning that almost more than a third of these patients have a mixed picture on a histology slide. And that, I think, is one of the challenges. I'm going to get to this in a minute. So I embarked on this survey, which I did with, Isaac Yang and a couple of the folks, and we surveyed people who defined themselves as neurosurgical oncologists. So this came from the CNS tumor section, Society of Neuro-Oncology, it was a survey study. So we ultimately got this out to about 400 people. And the question was, how do you identify and then manage progressive enhancement following radiation for brain metastasis? And how does, LIT affect that? So we had about a 30% response rate, which is expected. And, you see that this is divided, across those physicians in terms of their access to radiosurgery and access to LIT. And one was that we, as neurosurgical oncologists, differ on how we define progression. Many of us say, well, growth on 2 scans spaced 6 weeks apart, but that's not true for all of us. And then, we're fairly divided on using a biopsy to distinguish between radiation necrosis and recurrence, sort of half and half. And again, remember, this is not the general neurosurgeon. This is the, neurosurgeon who defines themselves as an oncologist. Now, the more interesting thing here is that the diagnosis based on histopathology is all over the place. Some people say you need, greater than 50% tumor cells. Some people say you need any tumor cells, equals recurrence. Some folks say any amount of necrosis equals radiation necrosis. And some people say, well, it's a case-by-case basis. So this was, I thought, one of the highlights of the study, that we are not on the same page as a group. Now, it's easy for us as a surgeons to say, well, I just leave it to the pathologist. But as you know, in a multidisciplinary group, we have to be a part of that, decision-making. So then the management then also differs based on your access. Now, if you don't have LIT, most people are using steroids. People who have access to LIT and have used and are comfortable with it are usually, using LIT earlier. And that, I think, is intuitive from what I expected. But I think one of the things that I wanted to, show from this is that we as a group are not on the same page with what we are calling recurrence versus necrosis. Now, I think that in light of that, if we talk about changing the question here, say that the question I think should be, what is the chance that radiographic recurrence or the enhancement will continue to progress? Because that's the question in the argument. The argument is, well, we see some growth on the next scan. Is it going to plateau, or is it going to grow? And so I did a surveillance study, looking at about almost 600 treated Mets. And what we found was that 100% of these that progress on 3 scans, and these scans are spaced out about 6%, about 6 weeks apart, go on to require some type of intervention. And this is not using any other tools that we have, not using spectroscopy, not using perfusion, not using biopsy. So I think that if we have look, I'm all for, and I would love your input on this, because I'm all for scientific investigation. But in my, from my perspective, I think that we have a baseline issue that we as a field are not defining these things the same way. And then we for example, put out literature, for example, that says, well, laser therapy is better than radiation necrosis for radiation necrosis in recurrent Mets. And we're not defining it the same way. It muddies the results. And I'll tell you recently, and Rick's on and Ian's on, we recently put a combined paper together that was a very good multi-institutional study, ultimately was going to get rejected because not all of these got a biopsy. So I'm going to leave it at that, but the idea I wanted to introduce to you and the panelists in the group here is that we potentially have a baseline issue that we haven't solved as we move ahead, with this field.
Shabir, that was a really nice, kind of summary of a lot of, number one, it puts a lot of nice data to some active questions, especially kind of that progression issue, where you basically see the little Met getting bigger and bigger. And because also a lot of times with the biopsy issue, sometimes you just don't trust it, because I think very commonly, I think that you have both radiation necrosis and tumor recurrence. And to an extent, does it really matter? I mean, that's why I think, at least, at WashU, I think increasingly the real question is, what's the morbidity of treating it early and then really putting that lesion to rest? Meaning, maybe it's radiation necrosis, maybe it's tumor recurrence, but in either case, if it gets bigger and has more swelling and becomes symptomatic, it's a harder thing to deal with. And so I think I completely agree with, look, if it changes after 2, I think it's time to, you can biopsy. And I think more often than not, we are, because of the issue that you brought up, that sometimes papers, editors don't accept a paper because you don't have tissue diagnosis, but I never necessarily trust the biopsy. Either if it shows me tumor, that's great. But if it shows me radiation necrosis, that doesn't necessarily rule out that there's some tumor tissue there that you're just undersampling.
Look, I mean, the challenge, Eric, is that, I don't want to turn into somebody who biopsies to get my paper in, because the flip side of that is that, look, if there's real data to get, then that's going to affect the systemic therapy, or we're looking for receptors, no question, we do it. But, we've all been there where you do a biopsy, you introduce some air and blood, and I know, and I'm not going to reference papers, but then your ablation, whether you're using Monteris or Visualase, is a little bit more tricky. You can't see the boundaries. The post-op MR is murkier, and you are unable to really assess your ablation. And then the question is, does it really change your ability to control? And then is that inability to control because we didn't get a great ablation because there's blood and air in the cavity, or because your biopsy was,
I hear you loud and clear. Again, I agree with you in terms of that air issue. Although I feel like we've gotten a little better with, again, just some simple rinkety dinkety techniques of really making sure that when we're taking a biopsy, that if we're pulling back, we really take a lot of steps to mitigate air getting into the system and stuff like that. But you know,
I mean, look, I'm sure we all do it. Just, and again, I mean, what I wanted to do as a panelist is I wanted to try to introduce some controversy. I didn't want to just.
oh, I love it.
So I'll leave it at that. I don't think we're going to have the answers here. So.
Yeah. But I would say, you know, on my front, I would really welcome everybody else's input. Is, you know, when you get a lesion that's enlarging, you know, that is again a met that's been gamma knifed, you know, before. I would certainly advocate sooner than later, you know, to deal with it earlier.
If you see a tumor on your biopsy, will the radiation oncologist retreat after lit?
I'd say here the answer is no.
Yeah,
I don't know
no.
elsewhere.
Because I think there's pretty good data from the Monteris users that suggests that, you know, although certainly there's the issue with sampling error, but if you see tumor on the biopsy, those tend to recur at a pretty high rate if you don't follow, you know, if you don't follow it up with some other treatment.
The only caveat I would give to that, you know, I remember when we first started lasering Mets, I think you really have to overtreat the volume. And I think part of that, what's different about a Met versus a glioblastoma is that a Met is, I almost feel like it's a more solid tumor, so that when you laser it, I think it heats up and literally the tumor expands. So, and you're basing your heating on the imaging kind of preoperatively. And so I tend to kind of really try to heat beyond the margin of the tumor. And I feel, just fully disclosing, I feel we get better control of that. I will have to, you know, vet that out with the data. But both, you know, Albert, Kim, and I, like our early experience wasn't as promising, but our later experience, now that we are kind of really treat beyond the margins of the imaging of the tumor, tends to do better. And again, I'd welcome everybody's input on that.
Yeah, we actually just published on that a kind of finding, Eric, recently with this idea of supramaximal ablation in Mets / radiation necrosis, and found that that in that cohort of patients specifically, that additional, you know, beyond the, I think it was 10% of the volume ablated, made a significant difference in controlling the long-term effect.
Oh, that's great. I haven't seen that paper. Please send me the reference. That's great.
Yeah, for sure. Ian, do you want to, I'm sorry, Claudio or Simon, when do you guys want to go?
Want me to do my case, then we move again to brain, change a
Sure,
little.
sure. Sounds good, Claudio. Show us what you got.
All right, let me just see if I share the screen here. All right, can you guys see it?
Yep, that looks good.
Okay, very good. So we're gonna show how we can apply this for spine, and you know, Ian has done two cases at Detroit, and you know, it's very doable, and you can really treat real cases. And so this is a case that I did last Friday, and it's an 87-year-old lady with recurrent non-small lung cell carcinoma. She has had this large paraspinal matter, has been irradiated with conventional radiation before, and approximately 8 months ago recurred, and then she was treated again with SSRS, and she's currently undergoing treatment with Pembro, and she's doing quite well overall, considering her age and comorbidities, but she was presenting this recurrence in the epidural space, compressing the spinal cord there. She was having some pain in the left side, going under the rib cage. This is T11, and you know, 87, multiple comorbidities, anticoagulated. I didn't want to do an open surgery here and ended up putting screws above and below. So that's a great indication for LEAT. And this is a little more, going a little deeper here on the situation. So on this column here, you see this is the upper portion of the body. Then you have a cut in the middle and a cut in below. When they do these MRIs, they do 6 millimeters, skipping 8. So that's all I have from this tumor. And on this other column here, on the third column, we're using a subtraction technique. So we are using the enhanced MR, the post-contrast, subtracted the pre-contrast, and you can see all the tissue that enhances. So this is the real tumor here that we need to ablate. The large mass was already dead, but the medial part here, the epidural part, was still active, and this is the corresponding PET showing that this was active. So this is the region that I need to treat. And you know, this is kind of how I plan these approaches. I get the the preoperative imaging, I flip in a way that is the operative position. So this patient is prone, the right side becomes the left side. But to treat this, we need to put a bunch of catheters in a kind of a complicated geometric disposition here. So first catheter we have to enter here, so we could treat this part. Second catheter we have to enter this, so we can treat this part. And a third catheter we have to crisscross, so we can treat this part here. And there is no way to do that without having, appropriate good navigation for that. So we initially we were doing CT scans, like a CT fluoro match, but it's very hard to do this in another room, transfer the patient intubated with a bunch of catheters exposed in the back. So we developed this way to do using basically MRI, and it's very similar to putting fiducials in the brain and getting an MRI to have navigation based on surface matching registration. So we apply the fiducials in the region of interest, then we mark an incision where in the spinous process where you can put a titanium clamp that is compatible with MRI. We prep, put towels, and after I have my clamp in place, I put this stereo bag covering the clamp, and then we put an MRI coil supported by this plastic cradle, so there is no contact and displacement of the fiducials. We then take the patient to the MRI and we do an image, we acquire the registration scan. This is a T2 scan with 1 millimeter cuts of the region of interest. And then we upload this to the navigation system. We have to play a little bit with the imaging parameters, but you can get this nice reconstruction here. And then you just do a surface matching and you can verify accuracy on the surface. So after I do this registration, I put my probe in the donut and I can see the donut here, so I know I'm accurate and I can confirm on the different other fiducials here. So another thing that I found to be very helpful is to outline the tumor. So after I export the image to the navigation software, I'm outlining the tumor, and that helps me guide my probes to the right spot. This is not that case. It's another one that I did that, where I planned trajectories that was kind of crisscrossing, and it was it was much easier to do that when I was placing the catheters. And this is the typical placement. On the top here, you see, we use a navigated needle. Once I have the target, I put a K-wire and we remove the needle. And then we put these introducers here. On the center here, this is how we approach bilateral transpedicular approaches. And in the bottom here is an example of the crisscrossing technique when you go translaminar contralateral. This is the typical, after we put the scatters, we go back to the MRI and then we do a localization scan where we have to find exactly the axial plane. This is just a video showing quickly how we place these scatters. We use navigation, and I play a little bit with the features of the navigation so I can have an idea of the ablated zone. On this example here, a second catheter would cover the entire tumor. I like to do an X-ray before I go to the final target, just to confirm if the deep position of the needle is accurate. And then we exchange the needle to a K-wire, and then we put the cannula. After the cannula is in the place, we remove the wire, the needle, and then we put this here to maintain the trajectory. So it's just rushing a little bit here. After this, we put these stereo towels, and we have to put the MRI coil so we can achieve the image for the ablation. So we again put a stereo bag, then put the MRI coils, then we put these towels, and then we apply the laser catheter. And if I have more catheters, I can do 2 laser connected. If I have like just 2 or 3, I just use 1 fiber. And after I finish the first cannula, I move to the second, and so on. Then after we connect this, we go back to do the localization scan, right? This is the localization scan. Once I have my scan, I select the points, and I select these points between the tumor and the dura mater here to protect, to put my safety limit. I like to use 48 Celsius instead of 50. And I always put a little other dot here, so I know I'm going to be having my my thermography there. We need to ask the anesthesiologist to do a ventilatory break. So and then we have our treatment. So this is the final position of the catheters for that case. You can see I was able to do very nicely, these complex trajectories here. And this is in the top part, this is in the bottom part. And this is a video here of the treatment. So this is this catheter here. As we do the treatment, we have this, every pixel that gets to the temperature compatible to cell killing, 50 Celsius for more than 8 seconds, gets yellow. And you can see an estimate of the treatment there. And then as this, the patient is in the ventilatory arrest. So I need to be, I keep this probably between between a minute and a half to 2 minutes. And then after I finish this, we do a pullback and we burn a little more on the surface. And then we change our catheters to another position. And this is finishing here. So this is the final result. This is the pre-contrast scan. This is the post-contrast scan. This is the entire a view of the entire field. Here you can see that I was able to get the entire epidural tumor. And here on the top corner here, you have the subtraction scan. And this is for comparison, the preoperative subtraction scan. So you can see that this area that we intended to ablate was completely ablated here. This patient did very well. She went home the next day. And just for comparison, this is a similar case. I still don't have the follow-up on that lady because it was last weekend, but this is another patient we treated 8 months ago with a very similar tumor. You can see how we can totally reconstitute the CSF around the spinal cord, decompress the spinal cord. And I find that laser plus radiation is very synergistic. You can see this part here of the tumor got stereotactic radiosurgery with the full dose, but still there might be some viable cells here, some tissue here. Here where I did the ablation is completely necrotic. And I think that's a very interesting, a thing that maybe we can explore better is combining radiation sooner, because I think that there is a window of opportunity where you have a penumbra around the ablated field that can be then better treated with radiation, having a synergistic effect. So that's the case I had to show. Thank you.
Fantastic, Claudio. Thanks so much. A couple questions for you. One, I noticed that patient that you started with was on Pembro. So did you hold that, or do you just treat through the?
Very good question. I just treated through it.
Yeah.
I have this theory that maybe we are activating the immunological system, right? So I think she's my 5th patient that I have taking immunotherapy. I'm gonna wait until a little more follow up to have like a better idea. But I think it's kind of, I don't know, hard to tell if there is a synergistic effect, but it would be very nice if you can demonstrate like an abscopal effect after bleed.
And the other question I had is, when you use the multi-fibers, I think we've all done it in the brain, but they're typically in more of a parallel trajectory and they're pretty spaced apart. But I see when you have crossing fibers, is there any concern about the distance between the fibers and when you heat them up, or how much time you need to wait for cooling in between them?
Very, very, very good question. I learned that by doing mistakes. I had a few times where I had my catheter in and I forgot to do the pullback of the Teflon catheter, and nothing happened. It didn't melt, and so after that I just don't have any concern about melting those catheters there, because I've done it quite a few times and never had a problem.
And go ahead.
One question I have, again, I think that's really, really cool stuff, is how have you found, because the thermal imaging is a phase sequence, it sounds like you put them on a, kind of, you stop the respiration, but just the tissue itself, how have you found the thermometry to be within that type of tissue?
I think it's very accurate. The spatial location of the temperature, I think, is very good, and that's why I feel safe that I can do these procedures.
Now, even in bone, like, so I saw that I guess maybe the tissue, like if it's true soft tissue, but like if it's in bone, you can still see it.
Yes, it doesn't work in osteoblastic tumors, because the very calcified bone the heat doesn't spread there. But most metastases are lytic, and when I have the tumor, the catheter inside the tumor, it's almost like any other mat in the brain, or it's a soft tissue.
Right.
And very vascular tumors like renal cell carcinoma, they tend to burn less. So I have to put more catheters in tandem. This lady had an adenocarcinoma, and that was, I think I could get 16 millimeters of diameter in my ablation zone for each catheter. So I chordoma, which is a disaster to, for spine. I have a few chordomas that I operated. They burn really well
Cool.
Hey, Claudio, this is Ian. A quick question. Do you ever try to do a biopsy through any of these trajectories?
Yeah, I did. Yes, quite a few times. I never had a biopsy after the treatment. I had a biopsy, as I'm putting the catheters, I need tissue confirmation. I get a biopsy there. I had two cases that I had to decompress because some other issue. One was a fracture, and another one was a real tumor failure. And the part that we ablate is really ablated. I got these two specimens separated. The part that was the ablated part, and then the part that was the tumor. The part that we do the ablation is just necrosis.
And how are you like when you do your final maneuver to the MRI? Do you just suture in all the laser catheters, or how are you securing them?
No, I just secure because they are deep. They are like very deep, right? So I need to be very careful. We put the coils, and then we put the towels around, and then I cover with another towel, and very carefully we move the patient. It's a problem. I had a case where when I was moving the patient in, I lost all the catheters. I had to go back, and extremely painful to have to position this again.
Yeah. But great work. Really, really great job pushing the limits on spine.
Absolutely.
Simon, you want to present the last case here?
Yeah, sure. You guys seeing that okay?
Yeah, looks good. Thanks.
Okay, great. Yeah, I have a quick case here. It'd be interesting to hear what everyone thinks, if they would have if you guys would have managed it similarly, or where you would have deviated. This is a 72-year-old female in pretty good health and very functionally independent. Presenting symptoms were occasional dizziness, a little bit of confusion, so nothing really profound. But because of the symptoms, she ultimately had an MRI done. She had a rather extensive workup as well that was negative, including a CT of the chest, abdomen, pelvis. After the MRI showed this. So let me see if I can play this video. Unfortunately, she had this MRI. This case is a couple years old, and her full MRI I just was not able to get, but I still wanted to really present this case. So this is the stealth MRI that we did before the procedure. And so it is a nice thing to see on the sagittal and coronal projections, which we will in a minute. But, at 72 and, with the tumor in this location, my presumption here was that this was a glioblastoma, really in the cingulate extending down into the corpus callosum. She was amazingly good neurologically, despite its size and really apparent infiltration into motor posteriorly. So I thought that she was a good candidate for a biopsy, and at the same time to do laser, with the caveat explained to the patient that, there's a theoretical risk, though low, that this might represent a lymphoma, in which case, if our frozen section strongly indicates that, we would not do the laser. But let's say the frozen section still indicated glioblastoma, and we ended up lasering this, and it turned out to be lymphoma. That would, I guess, be considered a mistake, a faux pas, what have you, even though some of that doctrine has been questioned more recently. But so that was essentially my counsel to her and her daughter, that I thought this was the best approach, as opposed to doing an open surgical resection of something like that in this age, et cetera. So I think that would be one, obviously, management decision that maybe some of the panelists might have deviated. Maybe some of you would have done this open, or just left it at a needle biopsy alone, which I think is reasonable. So we could talk about that in a second, but I just want to show, how we place this laser. And this also, like I said, gives some better views of what we were dealing with. Obviously I placed a white arrow here on the laser probe. And because of the biopsy, something that Shava and Eric had discussed, you do introduce a little bit of air and a little bit of blood, and that could sometimes, complicate the ablation, or at least the damage estimate or the thermal estimate accuracy, at least on the visual laser system. So this is where we placed. I was satisfied with the placement. I knew going in that given the way it kind of bled anteriorly and posteriorly, the enhancement, that this was going to inherently be a subtotal ablation. So whether or not that might have steered some of you away from even offering ablation is another question, right? Because this is not something that we would really be able to get a full ablation on based on its size, unless you wanted to consider utilizing other laser probes, which I think probably would have been still difficult to have gotten all of this. So these are some images from the ablation. This is really towards the end. Again, the visual laser system here is showing the damage estimate. And maybe the ablation volumetrically here got into the 80% range at best, perhaps, but I think a reasonable ablation here. What I found interesting about this case, and partly, one of the main reasons I wanted to present it was, this is a patient that did not do well from this. So I think it would be interesting to hear if there was some insights into why she didn't do well, and I'll explain how. But this is how the ablation looked. This was the post-op day one, not the immediate kind of real-time post-ablation scan. And I was fairly satisfied with how this looked. I thought it had some of the, there's a little bit of motion there, but I thought I had the fairly characteristic kind of rim enhancement outside the whole lesion, and then some of that, enhancement in the core. But I thought that it represented a fairly meaningful ablation of this target. So post-operatively, she woke up, she was very impacted by this. Cognitively, level of arousal significantly diminished. I mean, it was a remarkable change, and I was stunned by it initially. And she also had some weakness on the right side. And this was not one of those thumbs up going home the next day. This is the opposite. So the pathology did confirm glioblastoma ultimately. We didn't really get meaningful follow-up on her because of how poorly she did. I wasn't getting her an outpatient MRI in 6 weeks and 3 months, and there was, she was in rehab, doing whatever she could do to recover. She did bounce back for a seizure, I think it was, and they just got a non-contrast MRI. They did not get a contrast MRI at that time. I don't even think that we were alerted. She came back to the hospital, but I did obviously look at the MRI, and the mass was stable, the edema was stable. I know without contrast enhancement we're limited, but it wasn't like this thing had exploded. So maybe the ablation did have some, at least, early effect in controlling it. We never ended up giving her adjuvant treatment. She just didn't do well enough. She ultimately passed 6 months after the procedure. And I know it's limited in terms of what you guys are looking at here, but I think some of the questions, maybe Eric, because you're leading the charge here, my best speculation here, looking at it and discussing it with a few people, was that maybe, I thought I put in a slide here to kind of discuss some of the issues, but I don't see it. But, oh, here, yeah. So, was I too aggressive with this ablation in terms of either trying to get too much volume, and going for as much of this lesion? Did I kind of heat it up maybe a little too quickly and aggressively? The ablation time here was in the 5-minute range, and that's not that long for a large lesion like this. And I basically heated it at around 90% of the total laser wattage. So the question is, and this is something obviously I worked close with Shaber for years, about whether or not you would kind of more slowly heat this. What are the kind of pertinent dynamics for something like this, or would you be aggressive in terms of the heat? And I just always felt that her exam severity, which was really remarkably poor, was out of proportion to the MRI. And there was nothing on the MR to suggest why that might be. There wasn't an infarct. Even on that subsequent MRI that I showed, the edema never appreciably increased. So, did some heat, was there some kind of collateral damage down into the thalamus? Potentially is one of the kind of the theories that I had to kind of explain such kind of a globally depressed exam. So, would you guys have not done it in the first place? Would you have done less volume? Would you have heated it differently? Would you have taken a different trajectory? Those are kinds of the things I thought were interesting in a case, because I think laser is a wonderful technology. It works well the overwhelming majority of the time, and it's a bit forgiving in certain ways, the way it preferentially goes into the target tissue, and the way it's difficult to damage some adjacent vessels, et cetera. But this is a case where, you know, for me, hands down, it's the worst clinical result that I've seen. And I was just wondering, you know, kind of, you know, what your thoughts were on this kind of a case.
Simon, this is a great case to discuss. Could you show some of the yeah, right there.
I probably should have provided some video of that too, because I do have that to really allow you to scrutinize it.
You only just, you know, some initial, you know, kind of thoughts, and, you know, and I had a case kind of similar to this in the sense that, but it was in the kind of more posterior aspect of the
More splenial.
corpus callosum, and, you know, and it was really kind of going, you know, almost butterfly-like, and we did 2 trajectories, you know, down both sides, and that was the corpus callosum treatment where my patient, I had a similar kind of like just really was severely cognitively impacted. The first thought that comes to my mind is, you know, was there more symmetric injury than we appreciate? You know, so for instance, if you had more injury to kind of that kind of bilateral cingulums,
Yeah.
could that, you know, really have led, because, you know, one thing that, you know, is really kind of, you know, ingrained in us is that smaller lesions, if symmetric, can have outsized functional effects. And, you know, because that treatment does really ride along that falx there.
Sure. Definitely.
And, you know, is there just some more, and again, it'd be interesting to see the T2 here. You know, is there, you know, a little bit more bilateral, you know, injury than the enhancement patterns giving indication to? Because for me, when I did this, really, you know, much more of I really went after a butterfly glioma aggressively bilaterally. I found that I really, you know, substantively affected the that patient cognitively.
Yeah.
That's just my 2 cents.
Yeah, no, I think you're probably, yeah, I'd said thalamic kind of unilateral, but you're right. I mean, maybe this kind of coursed across the callosum into the bilateral cingulate and just really, yeah, because the examination was just, she was
Like
just
kind of a stunned, kind of like, you know, lobotomized quality.
Yeah, totally stunned, barely moving the right, barely communicative, barely interactive. Just, it was just a disaster.
I mean, again, I'd be curious to see the flare of the T2, because I wonder if there's a little bit of that bilateral nature.
Yeah, I'll look at it again. It didn't really course across that significantly, but it might not have needed to be that significant to have induced the injury, given kind of how much, you know, how much of an ablation we did there on one side. Maybe it was just enough to trickle over to really cause the problem.
The other question that I think about, and you said she was a high functioning 73-year-old.
Very, yeah.
Here's a question: is so, you know, was she a well-educated 73-year-old?
Yeah, I mean, the daughter was a bit more, but yeah, she was pretty sophisticated.
No, the reason I ask is sometimes, you know, you can have somebody with a compensated dementia, meaning that, like, you know, they're functioning well, but, you know, they're right at the S curve, and basically kind of these people who have kind of, you know, preclinical dementias that, you know, you do something like this and it just pushes them over their edge of tolerance. That might be another issue.
Yeah, it's interesting. She wasn't perfect. She loved her cruises. She was up from, you know, she was a snowbird.
Right.
So I got to know her actually in the family pretty well even beforehand. But you're right. I mean, she was, you know, it's a possibility for sure. I mean, she was definitely not perfect, but she was independent.
Mm-hmm.
Yeah, I mean, Simon, I mean, I agree. I mean, I think that everything was appropriate here. I mean, obviously, when she woke up like that, my first assumption would be like an SMA syndrome, that she would have had dominant left frontal lobe. You know, it's really close to motor. The only thing that I've had is I've had a couple of these, not a couple, I've had one patient too where I've been trying to be really aggressive on this tumor where I knew going in I wasn't going to get a complete resection, and it was surrounded in all 4 areas by eloquent area. And, you know, you fight that battle of, do you want to ablate the tumor that's closest to the eloquent area because that's the part that's going to invade next, or do you be a little bit more less aggressive in the eloquent area because you know that you don't want to cause harm? And so, you know, and I think I've tried both and got burned with being more aggressive. And so in these tumors where I know that they go in multiple directions and there's no way you're going to get a 100% ablation or complete ablation, if they're surrounded by eloquence, I tend to be a little bit more conservative than not. But that's just my own.
What I guess, was she paretic at all?
Yeah, she was.
Oh,
She
okay,
was,
okay.
She was very weak on the right. She was definitely not out. She was borderline anti-gravity, but she was weak on the right, which was new.
Yeah, I think Michael's point about it, because SM, there have been studies out there that basically, when you do kind of that medial, frontal lobe associated with SMA, and you include the cingulate, like that is where you get more profound SMA. So I think that's
I think that's a good point. Though the weakness never really got better, and her overall level of arousal was diminished, but for sure speech was considerably compromised. So she definitely had some of the hallmarks of that. There's no question.
Yeah. Okay. Well, we're already 10 minutes over time, and so I don't want to. I know we have a bunch more questions to go here, but we'll try to take care of them offline. But I just want to say thank you to Eric and all of our panelists for their time tonight. This was really a phenomenal session, and I think we'll be watched many times on YouTube. And thank you all again for contributing, and I hope everybody stays safe.
Great. Thank you very much. It was a pleasure.